2025. I'm living in 2026.
Okay.
So welcome everyone. I'm Becky, Dr. Williams. I think I pretty much know all of you guys, and you guys kind of know a little bit about me. But we're gonna start with Jim. So Jim is with Chefla, which is the parent company that manufactures New Tom. So New Tom is the brand of CBCT. So CBCT, cone beam computed tomography, and the machine that I have is just across the hall. We'll go look at it a little bit later. It also does CineX, so that's what today's all about. CineX is a video fluoroscopy, and Jim is gonna tell us a little bit about himself, and we'll get started. Thanks for being here.
Thank you. Well, thank you all for having me. I haven't seen David since yesterday in North Carolina. We had a big sales meeting this week. So I feel like I've been standing and talking for at least 2 weeks straight. This is kind of what it feels like. So my name is Jim Norton. I'm the Senior Product Specialist for Chefla North America. I've been with Chefla North America for about 10.5 years, but my experience with New Tom goes back to when I used to wear dad jeans and carry 2 cell phones on my belt back in 2003, as all the cool guys did back then. So started out as a technician, so I know the hardware in and out, and then learned the clinical piece as I went and became a product specialist. Went to work for a competitor for a few years, and then as soon as I could get back into dental imaging, I came back to Chefla. I love our company, and the reason I love our company is because we're unique in today's environment. So Chefla, our company, was started back in 1932, and it was started by 11 tradespeople that all chipped in 100 lira at the time to create a cooperative. They wanted to all work together and have their own employee-owned corporation. So they started what was Cooperativa Elettricisti Fontanieri Latonieri e Affini, and forgive my Italians, butchering that. And that's what Chefla is. It's a cooperative of electricians, plumbers, metal workers, and the like. And we're 96 years later, and we're still an employee-owned company, much larger now. We have 300 blue-collar workers outside of Bologna, Italy, that own the company. They make the decisions, they elect the board. We, as a Italian cooperative, we reinvest a vast amount of our profits by law every year back into the company. So we do spend a lot on research and development. That's why we're very innovative. We also acquire struggling Italian companies as well. So it's an interesting company to work for. Of course, since I am not Italian, I can't own a piece of the company, but
You look Italian.
exactly. I look Italian, is that what he said?
Yeah, a little second.
I'll take that. So just a little more about our company. We have 4 divisions. We have our medical equipment division. We have a finishing division, which we also have at our headquarters in Charlotte, North Carolina. They're much larger than we are because their machines are much larger than than we are. They do robot paint sprayers, equipment machines that they emboss, print, do texturing on all kinds of surfaces. So cabinet makers, flooring makers all purchase these equipment from that division. I was actually on a flight one time and somebody saw my Chefla shirt and they're like, "Oh, I love your equipment." And I perked up, I'm like, "Oh, great, what do you have?" I'm thinking I'm talking to a dentist or a doctor. And he's like, "Oh, I've got this machine." And I said, "You sure it's Chefla?" He's like, "Yeah." I go, "What do you do?" And he's like, "Oh, I own this cabinet shop in Maine." Oh, that's our own division.
Too, yeah.
So we also have an engineering division, and what they do is they redo power grids at factories focusing on renewable energy. So they're actually doing the great work of making people's lives better, which is our new motto for Chefla. And then one of the acquisitions we did a few years ago was a struggling company called CLED, just across the highway from our factory in Imola. And they make compact fluorescent LED lighting, which we use in all of our products, so we just acquired them, brought them in, and helped things work with them. On our medical division, we're talking about New Tom today, but we have multiple brands across multiple categories. So we're the largest manufacturer of dental treatment centers, dental chairs in Europe. under 3 different brands, Castellini, Sternweber, and Anthos. Under imaging, we have the MyRay, which is more of a dental machine, and then the Newton, which is more of the medical type machine. And then we also make sterilizers, and because it's still trendy, we have an implant company as well for dental implants. All right, so talking about cone beam CT, the machine we have here, the VGI Evo, we launched that in 2016 in the US. It's a great machine. We usually, what we call a refresh on our products every 2 years. We haven't had to touch that because it's just perfect. There's a few things we can do with technology and do touch panels and those types of things to improve it. But for a functionality, it's perfect. It's a far cry from this machine that I used to install back in 2003, which was our first product. It was the DVT 9000. 9,000 was the weight. It felt like sometimes it was a 900-pound machine. The scan time on it was 1.25 minutes. Now we're 10 seconds. You do 11 seconds, your high resolution scans are 15 seconds now. We were 60 more seconds on top of that to scan a patient back in the day. And it was an 8-bit system, so 256 shades of gray. So it was either black or it was white. There wasn't a whole lot of soft tissue visualization, especially what we have on that 16-bit VGI Evo system. And then just a couple more things. Our product line. So we started out with those older machines. We went with a vertical generation, or VG. We've always had a combination of supine machines, vertical machines, and then in 2013 we started doing hybrid machines for dental, where we had dedicated 2D sensors that would do panoramics and more dental imaging, and then have that CBCT component on that. And then 2020 was a great year. We launched our 7G, which is the most advanced cone beam CT in the world. It has a multifocal spot X-ray head, which is what you'd see in a medical grade, a multi-slice CT, and it can do bilateral hips and shoulders, and that's something that we just don't do with CBCT. So that's a great machine as well. All right, but we're here to talk about the VGI Evo and the functionality of that, specifically CineX mode. This was a great machine because we redid the imaging chain from previous machines, so it has a brand new detector type for it, and then the X-ray head was a rotating anode X-ray head, so we can increase the MA, get really good soft tissue visualization. Not to where we can see the disc in the TMJ yet, but we have really good visualization on that. So CBCT on that one. We also have a feature called Sharp 2D that allows us to do a low dose volumetric scan and then create cephalometric and panoramic images for dentists as well. And then of course, we also happen to have CineX mode, which is our version of DMX. All right, speaking a little more about it. So CineX mode is going to be digital motion X-ray. We can do it in a anterior-posterior orientation or lateral orientation. We can take dynamic motion X-ray up to 32 seconds, and it's usually about 28 frames per second until we reach that 26-second length. Then it reduces the frame rate to keep the overall dose low. And this is a standard feature on the VGI Evo. It's not an upgrade, it's not anything you have to add to it, it's just included in that. So I know that there's some people that are buying a DMX and then interested in buying a cone beam CT. We've got that all in one compact package. And so how this works is we'll set our orientation, whether we're gonna do lateral or frontal view on the patient. We'll set our time. We'll take a scout view to align the patient, and then we'll take the acquisition. We'll have them do whatever the motion is, whether it's flexing and extending. If we're gonna do airway, have them breathing, or opening and closing for TMJ. And then when we play that back, we have our screen within NNT, and then what we can do is play those sequences back, let them run. We can stop at any point, pause, advance single frame at a time. Single frame at a time, there we go. And then reverse. So we have all that functionality within the software to view that. So we can see if there's translation of the spine. We can see if there's a misalignment of atlas. We can see all of those with this single view. All right, so again, this is the scan I showed you. So for cervical spine, again, just flexing and extending, and then seeing if we have the S curve or if we have our nice C curve like we need to have for craniocervical. We can also do the lateral motion. I don't have a video of that, but it's possible with the VGI Evo to align the patient and then have the lateral extensions. Check that.
I've got videos of those.
What's that?
I've got those videos.
Do you?
Mhm.
Can I have this? Can I have some?
Sure.
I don't know what, for sure, that'd be great to have.
I've got some interesting ones, but for cervical spine, this is really the only case I've been able to get from all my other counterparts across the world. So some of the other things we get are TMD or TMJ for diagnosing TMD. So we can take this in a lateral view, so we can watch how the condyle dislocates and then resets to see if there's any function of that joint. It's crazy. We can also do that in the frontal view. I like this one the most because you can actually see there's kind of an S-shape motion to that. So there's obviously some clicking, there's some joint issues there. I'll put that one again, in case you didn't see that. Yeah, see that? Once you see it, you see it. So that should just be straight down, open and close.
Yeah.
So we can definitely see that there's some issues there with the temporomandibular joint. All right. Dysphagia, so if there's swallowing issues.
Cool. Yeah, that's cool, right?
That's so cool.
So we can see if maybe there's some acid reflux, if there's some polyps or some pathology that's causing that. Any issues with the swallowing, we can see that right away. And again, these are all very low dose, very quick acquisitions. We set the patient up, we have them do whatever their motion's gonna be, drinking, swallowing, breathing, opening and closing, and then we can play that back. It exports to PACS, so if you're in a hospital environment or a clinical environment where you need to upload that to a PACS server as well, it's just a very easy way to save it as a DICOM file and then kick that over to your PACS system and upload it to that. So very accessible.
And it's nice with that, it's like a modified barium swallow, but there's no barium. You can just drink water.
Yep, you just drink water and you see it go through.
That's cool.
I was just gonna ask that, I was just gonna ask, there's barium in the water, but it's not.
No, just regular water.
So some other uses, we use it in the vet with barium, the vet industry. So this is our 7G, so it has a table for the cat to lay on. And so, looks like they must have starved it first because it's going at that.
No, it'd be like my cat.
Huh. It kind of like fills the whole esophagus rather than like when we drink it just goes straight down.
Yeah.
Very
Well,
nice.
I think there's pathology here that's keeping it from going.
Oh, I see.
Yeah.
Okay, so it's not normal.
Yeah, so that's definitely not normal for a feelizer to go that way. Because their stomachs are gonna be down below here, below their heart and lung cells.
Sweet.
Yeah. So again, just very quick ways to diagnose. Some other things, orthopedics, hand and wrist, checking the functionality of there.
Yeah.
Yeah.
You probably get an ankle if you did it right.
Yeah.
And then if you're a radiation geek like me and you get bored one day and you decide you wanna make little videos of thumbs up and then thumbs down,
Okay.
did that as well for my Facebook responses to people.
Yeah.
It got really old really fast, nobody liked it.
I have a friend who, he's an instructor for the Blair technique, and one of the first things he did when he got his CBCT was our adjusting is where we kind of stick a hand out, and then the idea is we're using the distal end of the pisiform. And so what he did is he actually stuck his hand in the CBCT to make sure that that's really what was happening, because you can feel it, but then you could really see it. And then he tried it in different positions. But the cool thing with this is then you could say, how about if I ulnar deviate? What if I radially deviate? You can really see what's going on the inside. So I'll have to do that next.
That's cool.
And I thought this would be fun, and it's funny because I broke my metacarpal when I was in high school, and you can actually see that there on this one when I'm doing my thumbs up. You can see that it's got the healing on there. All right. So any questions as we're going? All right. So what I wanted to share is one of our customers is called Slam Labs. And so they're doing a unique thing using CBCT along with the CineX mode for Airway. And so you said you were doing TBI stuff? So this company, or actually it was just a person at the time, came to us because he had a vision for redesigning helmets for the military and for football helmets, because when we tighten a helmet, all we do is we're pulling on a chin strap and we're loading that joint up. And he thought there's got to be a better way. They thought there was some coordination with that and CTE, just a pounding of that joint. So he was trying to find a way to make a better helmet, and he wanted to have the Airway, C-motion, wanted to open up Airways as well, while they were also creating these mouthpieces that would cushion and protect people when they get hit or fall down or whatever the issue is. So their Slam Labs are in Boca Raton, Florida. And so what they wanted to do is use the VGI Evo system to diagnose airway issues and then temporomandibular joint issues. And so we created a protocol with them. And so what they do is they'll take, and did you know you can do this with your CineX?
Yeah. The colors? Mm-hmm.
Yeah.
No, I didn't know.
And so what they do is he's got a jig, a bite jig, that he can increase or decrease by 1 millimeter at a time at steps. And so with Airway, what they find out, at some point, as you start to open the airway, it's gonna start diminishing. You're gonna get a diminishing return on that. So there's gonna be a sweet spot in here. Excuse me. So what he does is we do a 6-second CineX mode where the patient swallows, opens, puts the bite jig in, and then we see how the airway opens and how those different settings affect it. So we're taking 4 different 6-second CineX scans. And we figured that they're about 90 microsieverts per scan. So it's a bit of a dose, but much lower than if we were gonna do this with a medical CT or just standard fluoroscopy. And so when we do this, we will scan, and then we'll have to find which one by measuring the airway, and then we can find out which at what point has the most open airway. And then what they'll do is they'll take that and we'll do a scan with the patient in full occlusion without that, and then do a scan with the bite jig in there, and then compare the results. And so not just looking at it in the radiograph area, but we can bring that into our do a 3D assessment of the volume. So this was just standard, and then that's with the bite jig in place, opening up that airway. So we're increasing the volume of the airway.
That's amazing.
This is for football players?
It's for football, it's for all elite athletes,
Okay.
or mostly what his patients are right now. And then,
And that jig, you said, is connected to their helmet?
no, it's not connected to their helmet.
Oh, okay.
No, so he creates a mouthpiece
Oh, okay.
that's set to open whatever we determine that ideal sweet spot is. If it's 2 millimeters to open the airway to get the higher volume, he'll create a mouthpiece that does that at the front, and then and for the molars, it has a cushioning effect. So it acts as a shock absorber to try to reduce that pounding of the condyle on the fossa of the temporal bone, and try to reduce concussions.
And he's doing this with all of his athletes? Like he'll do the image for them specifically?
Yeah, he's a lab.
Oh, okay.
So he started out with the end in mind. He wants to make this and do this. So he works with another great story. One of our other customers that has a VGI Evo. He actually, it's a really long story, but he's a great guy. He ended up needing to get a machine installed in his, and we had to do some cutting of the roof because our previous VGI, we had a flex version that had a smaller column that could fit in a van and be mobile. The current VGI, that's way too big to fit in the back of a Sprinter van. So we had to do some creative work. The person that owns Slam Labs, Norm, he's an artist, and he loves to cut things open and do all that stuff. So we were talking with him, same area, and those two got together, fixed the van so that it could accommodate the VGI Evo, and so now he's taking the scans for Norm. So he was a
mobile lab.
Yeah.
Or mobile imaging lab.
Yeah, exactly. His name's Herman. He was a dentist in Colombia. Had his family there, the practice and everything, and loved it. Did everything well there. And then one day the FARC rebels came and took him to the hills of the mountains or wherever they go, and said, "You need to come treat our guys, or something bad's going to happen to your 2 young daughters." And so he grabbed his stuff and they fled and came to the U.S. So he's a licensed dentist in Colombia, but he just does dental imaging here as that. But he's a super great guy, and he's working with Norm on this. So with our Airway tool, we can compare we can actually quantify the increase in volume from this. So we can see that our volume before, or just in natural posture, was about 22.38 centimeters for that lower airway. And then with the jig in place, 30.4 square centimeters for that. And so that's really an increase of 30% airway that we're doing now. For elite athletes, I mean, they're taking steroids that have all kinds of long-term effects just to get a little bit of an edge, right? So if you can give them a natural edge, like increasing their VO2 max, they're gonna have better performance. There's also the debate whether or not increasing the oxygen intake reduces the buildup of lactic acid as well. So you could actually increase your endurance by doing this. So there's all kinds of benefits from opening up the airway and just letting everybody breathe better. And again, this is a combination of using that CineX along with our cone beam CT.
That's cool. I feel like they should do that for like a mat. People will wear those mandibular advancement devices, so like any kind of a sleep apparatus. Hopefully they're doing this.
Yeah, no, they're definitely doing that. I actually asked them to create a night guard for me. Well, I can do my own. You know, my dentist is going to charge me $500 for a night guard, and I've got an intraoral scanner, so I can scan myself.
There you go.
Send it to him, and he'll make my night guard for me. So,
I got one too.
what's that?
I have it too. The same thing.
Yeah. Okay. All right. So what other questions do you guys have for me?
Questions?
It was a little brief presentation, but just kind of go through the nuts and the bolts of what we can do with CineX mode. Again, the scans are anywhere from 0 seconds up to 36 or 32 seconds is the duration of that. That's a long time to radiate somebody, but if we're looking for flexing or extending, we can see that. We can see if there's any translation again with the spine. Check the spine shape, make sure that the cranial stability is there.
You said 30 seconds is like 90 millisieverts?
So the 6 seconds is. So 6 seconds is about 90 microsieverts.
And then what about a full CBCT?
So the full CBCT, if you do The highest one, if you do the 24/19 boosted at the best quality, it's gonna be 350 microsieverts. We figured the whole whole protocol that we're doing is about 750 microsieverts for that process to determine which is the best jig and then create the guide from that. And then also do the TMJ assessment.
Yeah.
And so still less than you know, like what a mammogram's about that same dose set.
Is there a minimum age that you could do? I'm just thinking like, you know, for the cranial instability, like in the DS community or something, is there a minimum age for it, or can you just do it if they can follow instructions?
If they can follow instructions.
Yeah, so for the CBCT, we recommend, we don't recommend it for patients less than 12 years old. So 12 years old is about our cutoff for recommended cutoff. But for all the CineX and then the sharp 2D scans on the BG1, any age, as long as they can hold still. Or not really for the CineX hold still, as long as they can follow the instructions and complete the motions.
And that's my typical protocol is 12 and up for imaging for like a CBCT. If they're under 12, I usually don't need to take imaging, unless they're not responding for some reason. And then,
And then you could use the eco mode too, which is very low limited.
Yeah, lots of low dose settings. We're all about keeping it as low as possible by either collimating the field of view, or doing the eco dose settings on that one. And then also it has safe beam technology in it for when we do our 3Ds. And so what that does is it takes scout views to align the patient, and it reads that image for the density of the patient and automatically adjusts the dose. So you never have to go in there and say small person, large person, density, play the guess the weight game. High quality results every time.
which is nice.
A true automatic exposure control.
Yeah, it's amazing.
Oh, I have some images to show as well, some videos, if you guys wanna see.
Yeah.
I hope we can see it on the TV.
Thank you.
Thanks, Jim.
It's 10 or no, it's 30,000.
Are you sending out are you reading them, Becky, or are you sending out, or?
I read them myself, and then I do send them out for a radiologist to review as well.
Yeah.
So I use a radiology company where I can post it on there, and then they will read it, and they also write a report,
Cool.
so that I can share that with the patient. Let's see, presentation.
Reports.
Are they?
And then I also create like a video, so I'll do a Loom video for patients. Generally, if I do any like advanced imaging for them, and so I can create a Loom video as like a screen recording. So then I'll screen record me going over their findings with them, because it's hard to explain in just a report versus if the patient can actually see, and I'm using my mouse to highlight things and they can hear me talking. So it's really helpful for them to know exactly what's going on. And a lot of times they're like, that went way over my head, and I say, great, share this with your chiropractor, your neurologist, your whoever it is, and that way they could see that too. Because a lot of times we can see on the CBCT things that you would never see on regular X-rays, and especially on the CineX. So it's really nice to have that additional information. And then I can also send them like the raw DICOMs if someone has software and they can look at them and they want to, then they can actually take the time to look at it. I know for me, like, I wanna see the actual images, not just the report. But then if you're like, I don't know what I'm looking at, great, look at the video and I explain it too. So, AI created this hilarious.
That's great.
You gotta love it. Tight of the spine. So first thing I wanted to review is just a quick overview of CCJ anatomy. So you may or may not have learned this in the past. It probably has been a long time if you have. But these are some of the things that we're looking at when I'm looking at a CineX. Is there instability in the craniocervical junction, so the CCJ? And the most common ligaments that we're going to be looking at are going to be the transverse ligament, which is what holds the atlas onto C2. So if someone goes into flexion and that ligament is unstable, then we're going to see that excessive motion of, especially with flexion. So we're looking at the atlantodental interspace. So that's the transverse ligament. And then we also are looking at the alar ligaments, which can be damaged from a whiplash injury as well. And with that, we're going to be looking at the open mouth lateral views. So there's a lot of stabilizers in the neck. This craniocervical junction is about 50% of the motion of the neck. So with flexion extension, 50% of our motion comes from occiput and C1. And then with rotation, 50% of the motion comes from C1 on C2, axis and atlas and axis. So the CCJ has a lot of motion, which is good because we need to be able to look over our shoulder or look up, but that means that we have a lot less stability. So if we have less stability, we're much more prone to injury. So those are kind of the primary ones. There's a lot of other ligament structures that create stability in the CCJ, but those are the two kind of primary ones that we're looking at if we're going to be doing CineX. Lower cervical. Oh no, this is more CCJ. Of course, gotta have a lot of CCJ because that's my thing, right? So here we're looking at a side view. So the side view here, this is the very front of the atlas. So this is the anterior tubercle of atlas. And then it's a ring, so it comes around and then it'll come around like this. And this is the dens of C2, lamina, and the spinous process. So lots of ligament structures in through here. We could do a whole nother topic, a whole other presentation on the myodural bridges. If you haven't heard of those, they're very, very interesting and really cool. So this is actually a muscle that attaches a bridge between the muscles of the craniocervical spine up in through here and the dura. The dura is the connective tissue that covers our spinal cord. So we've actually found, that maybe about 10 years ago, this is discovered, there's actually connective tissue that connects those two. So when you move your head, it's actually pulling on your actual spinal cord, which can be good or bad. So those are kind of the main structures we're looking at as far as the CCJ goes. So if we have damage to the transverse ligament, then when the neck goes into flexion, it's gonna open up this space right here, ADI. And if this space is opening, that means this space is closing. And in here is brainstem and then the spinal cord. So this would be the medullary spinal so that's where it goes from the medulla of the brainstem, and then it turns into the spinal cord, basically right here. So if there's a problem and there's accessory movement in here, especially with the myodural bridges and the dentate ligaments and all the things happening, all the structure happening there, that can have a huge effect on the brainstem. That's why a lot of these patients have POTS-like symptoms, dizziness, headaches, vertigo, lots of unexplainable types of symptoms. Lower cervical spine, when we're looking at flexion extension, we can see damage. This is the anterior longitudinal ligament. And then we have on the back side of the vertebral body, so in front of the spinal cord is the posterior longitudinal ligament. And then we've got the interspinous ligaments. This one's a ligamentum flavum, the yellow ligament. And then we've got interspinous, and then ligamentum nuchae, nuchal ligament. Nuchal ligament is the one that you can kind of feel in the back of your spine when you go up and down. It gets tight when you look down, because that's that nuchal ligament that's really strong. If you look at some people on an X-ray or CBCT, they have, it's really popular like maybe 5 years ago on social media to have a horn on the back of your head, and that's from excessive tension on that nuchal ligament can cause external occipital protuberance, that part can grow. People would have a horn on the back of their head, and that's just from that tension of that ligament.
That must have been your algorithm.
Yeah, definitely my algorithm. So we're looking at flexion extension injuries. We're primarily looking to see is the primary things we would indicate would be wrong. We don't know exactly what's going on because we're just seeing that things are moving. We can't see the actual tissue unless you had an MRI. But if you had an MRI, you'd be looking for damage or disruption of ALL, PLL, and interspinous. So kind of the primary ones. Okay, symptoms of craniocervical instability. This is one of those word thingies, I can't remember what they're called, but basically the bigger it is the more common that symptom is. Number one being headache, dizziness, lightheadedness. We love dizziness. I always ask, is it vertigo? People don't know really what vertigo means, but is it spinning? That's vertigo. So that's like you turn your head and the whole world is moving. That can be helped with the Epley maneuver. If they've failed the Epley maneuver and they still have vertigo, then that leads us more towards a craniocervical problem. So dizziness, lightheadedness, sit to stand, POTS-like symptoms. It can be POTS where it's orthostatic, postural orthostatic tachycardia. So people go from sitting to standing and their heart rate starts racing. Some people, like I was talking to Lynn earlier today, she's like, oh, you know Lynn too. She woke up in the middle of the night and her heart rate was 150 for no reason. And we figured out it's because she has craniocervical instability and she was sleeping with her head down. And for her, she's got damage of those ligaments that hold things in place, so it's putting a lot of strain and pressure onto her brainstem. The Centennial Schultz Clinic is one of the 2 clinics in the nation that does stem cell prolotherapy, PRP, injections of the CCJ. So they're in Colorado. They do a lot of educational stuff. Their website's really good too. But they have a functional scale. So the highest performing people, they pretty much live a normal life. They might have difficulty with doing extra strenuous motion, but they can pretty much live a normal life. Mid-range, they're probably not gonna be able to exercise, significantly causing a flare-up. Low functioning, they may or may not even be able to work and have a job because they can just have symptoms in a heartbeat where they just have to drop everything. And then lowest functioning, they can't do hardly anything.
Is this similar to like functional neurological disorder?
Yes, and that would be Dr. Ben's specialty.
Okay.
Functional neurology is what he does. So I think of it as the 2 different components would be hardware and software.
Mm-hmm.
So what I do is the hardware. If things are in the wrong place, we've got physical problems, there's a misalignment, that's something that I can help with. And if it's been like that for a really long time, the software is all messed up too. So then that's where something like functional neurology, vestibular therapy, those types of things will help the software to get an upgrade. Static imaging, dynamic imaging both have their functions. So the CBCT allows me to really get a good view of alignment, very high resolution. We can see really, really good quality pictures. But they're just a moment in time. It's not dynamic. You can't see what's actually happening. If you were to look at a patient's CBCT, you would not know that they had ligament instability or CCI. But then you take the video and you're like, oh my God, that's why. Like that's why they feel the way they do, or that's why they're not holding, or that's why it gives you more of those answers. So the DMX, CineX, video fluoroscopy, lots of different names for it. But this allows us to see actual movement, actual function, and where is the instability happening as well. It's less quality of imaging. You'll see on the videos, like we saw before, you're taking something 3D and making it 2D, just like a regular x-ray. It's not gonna be as good of image quality as it would be with the true CBCT. If we could do a CBCT video, that'd be the coolest thing ever, but we're a long time from that. I don't even know how that would work. Yeah, that'd be crazy.
Yeah, we're trying to prevent motion with the CBCT, that's the problem.
Yes, yeah. Referral indicator, so who would need to have this type of imaging? Complex cases. You have your people who just don't respond the way that you would expect. Like for chiropractic, you do an adjustment, they have amazing results, and then 2 days later, they feel terrible again. So when you have that, their body was like, yes, I needed to be in alignment, I'm happy to be in alignment, and then they're just out and they just don't hold their adjustments well, that's where they could have some instability, which is causing it to revert back out again. Persistent symptoms that just are not, just like your complex cases. When you have tried everything else and just nothing is working, that's where it's nice to have that next step of what should I do next, and then you do CineX. So I don't do CineX on every single patient, but I do it on the patients who are not responding the way that we would anticipate. Or unless they like really, really want it. Okay, so videos. Any questions before we go over to imaging? Go. Okay, let's see. First, we can look at a CBCT. So this is a patient who, let's see if we can get that to come just a little bit prettier. Depending on the patient's age, I'll do like what Jim was talking about. You can do like the eco mode, or you can do different settings. So if someone is maybe gonna have kids again, then I will do a lower resolution image. If someone's like 60, then we crank it up, and also because they have a lot of degeneration or they have a lot of metal, then we have more artifacts, so it's nice to have a higher quality image. So this is a patient that's got all of those things on that word diagram picture: headaches, neck pain, POTS-like symptoms, dizziness, all of the things. And with the CBCT, we get that really good 3D view. She's got a few interesting things. Anything anyone notices right away that looks abnormal? Yep. She's got a non-union of atlas. So C1 should be a full ring, but the back did not fully fuse together. So this is very likely pretty dense cartilage, but we just can't see the cartilage on here. So we've got a non-union of C1.
Is that like genetic, or is it? Oh.
Not necessarily genetic, but they consider it a congenital anomaly.
Mm-hmm.
There's no way to know for sure because we don't have, CBCTs from when she was a child, but this should fuse by about 7 years old. So the going theory is that there was an injury to that growth center before it fully fused, so it caused that to stop. Yeah. Yep.
How do you repair that? I mean, what do you do for that?
Nothing. Yeah, just leave it alone. It's likely very stable,
Wow.
but for some people, they would, you wouldn't want to put a lot of pressure right there. Not that, I would do that with my adjusting anyways, but you might consider not doing an adjustment on the posterior arch. Like if I did a different type of like if I was a knee chest chiropractor, they have people with their head down, and then you go basically line up on here and put like a 30-pound force into their neck in that spot. I probably wouldn't want to do that for this patient.
No.
Are you gonna break it? Very, very unlikely, but do I want to find out? Definitely not.
No.
That would kill them. So she's got that. The thing that we see a ton on CBCT is this is a calcification of the stylohyoid ligament. And at 40 millimeters or more is considered Eagle syndrome. So she would probably be in that category. I'd have to measure it, but she looks like she's probably 35, I would guess. And the problem with the stylohyoid ligament is that it runs, so from the styloid process and then down to the hyoid, stylohyoid. The problem is that when this calcifies, it's no longer flexible. So now we've got this rigid piece of bone, and in between the front of C1 and this space, right in there, is the jugular vein. pretty important. That's all the blood flow coming out of the head comes right through there, and on that, around that, kind of right on the sheath of the jugular vein is the vagus nerve. You've probably heard of that. It's very popular these days. If you have the same algorithm as I do, it's definitely on there. Vagus nerve, very popular right now. It's probably because we have the internet, so people are like, what's wrong with me? And they have all these symptoms, and it points to vagus nerve. So vagus nerve issues, digestion, anxiety, dizziness, headaches, so these vagus nerve stimulators to help with migraines and headaches. So if there's physical pressure on the jugular, that's gonna cause pressure in the head, can cause vagus nerve issues. So that's a really helpful thing to know if they have that stylohyoid calcification.
And for Eagle syndrome, can you just, for the medical people, can you just explain what that is?
Eagle syndrome is the
Like
calcification
symptoms. Yeah.
of that ligament.
And what would the patient feel?
Headaches, dizziness, kind of all the
All these
same kind of things.
Swallowing.
Swallowing
is a big one.
difficulties, numbness and tingling. Yeah. So the medical methodology would then be to remove it. So they actually do surgery where they go in and cut it out and remove that portion of bone. And for a lot of people, they have pretty good success with it. From what I've heard, a lot of people have like a 50% reduction in their symptomology. So, something to consider. I don't do that. But it's also helpful. One of my mentors, Dr. Scott Rosa, he talks a lot about giving the patient the dignity of a diagnosis. So when you have someone who's had so many issues and they've been told by so many providers there's nothing wrong with them, to be able to have this imaging and say there is something wrong, and we can point to that and we can say this is the reason. Even if they decide not to do surgery and remove that styloidectomy, at least they know the reason why it's there, and they're not just in the dark wondering what's wrong with me. Nobody knows what's wrong with me. That's a terrifying place to be. Just have no idea what's going on. So giving people a dignity of a diagnosis is huge.
This was a patient of yours, correct?
Yes, yeah.
What does the presentation look like on an x-ray? Just a regular x-ray?
So we don't take x-rays, but we can turn the CBCT into an x-ray because it's a series of slices. Basically how that CBCT works is it takes 600 x-rays all at one time, and then the computer puts them all together. Because it's ultra low dose radiation, it's less radiation than a standard series of all the images. So this is a one slice. So this, am I correct on?
You're absolutely
Okay.
correct.
I was saying you could be a
I think I should just taught Dave something.
Yeah, there you go. So this is a 300 micromillimeter slice, so a third of a millimeter. So very, very, very tiny slice, mid-sagittal, so right down the middle. You can also use this to overlay all of the slices together. So if you were to take a lateral x-ray, that's what it would look like. And then
I was just curious if the Eagle syndrome would present on an x-ray, you know what I mean? Cause you'd see the non-union, but.
Nope.
Yeah.
They can on like a
You can't see it?
piano sometimes, like a panorama.
Yeah, if you get it, because then you're getting kind of that around the side view. The problem with the stylohyoid is it's right here. So it overlaps with the back of the
blurred.
mandible,
Yeah.
so it's really, really hard to see.
Yeah, you get like maybe even like a dual image, you know.
Yeah. But this, we could actually go through, make it a smaller slice, we can look right here. Ooh, this is a very cool view of it. So this is what I like to show people because this is an axial slice. So back of the head, teeth, we're flip-flopped. I have to update that. This is the right and this is the left. That's gonna mess me up. My laptop, I realized last week that it was too old to do to view this software, so I bought this laptop yesterday. And I installed this software just now. Oh, I can't see the OK button. Flip? No. Okay, we'll just pretend. Okay, so this is the right and this is the left, but these are the stylohyoid ligaments right there. And then here is the anterior portion of the lateral mass of atlas. So there would be the jugular vein. And she's got a little bit of room, but not a ton. And then you can imagine if she had a misalignment, which she does, so for her atlas is shifted forwards and on the left, which is the side. So what we did with her adjustment was we opened up that space by adjusting to bring that C1 backwards, to open up that space. Even if it's a millimeter or two, that can be huge for getting that jugular vein to pass. And the most common symptoms I see with that is headaches, migraines especially. So that's that style height, and then we can move this around and look at all the pictures. Other cool things that we can look at on the CBCT because of the resolution is you can see the inner ear. So I use a lot to look for superior canal dehiscence, which is the mobile third window syndrome, if you've heard of that. So the superior canal, part of the inner ear for balance. So we move, that fluid moves, and that's how our body knows where we are in space. And there can be a thinning of that little piece of temporal bone that caps that superior canal. And if there's thinning of the bone, or if there is even a hole in the bone, people feel like they have to pop their ears are very full. Autophony, which is where you can hear your own voice echo in your head, you can hear yourself swallow, you can hear your eyeballs move. It's because we have that opening of that inside of the ear, and we can actually see that on the CBCT, which is really cool. I think both of the patients recently that you referred had that superior canal dehiscence, but they didn't have the symptoms, so that's good. But interesting, and MSK Readers is the one who caught it.
Yeah, oh, great. And the machine that Becky has gives an incredible image of the ear. There's a lot of CBCTs on the market, and nothing can capture the ear like the machine she has.
Yeah.
So.
Yeah, I have other colleagues and they're like, how did you see it? What was that?
Do you have some pictures?
Ooh, yeah. Okay, let's see if we can check on Robin's.
There.
Easy to fit.
Yeah.
I got some cochlear implant scans, which are really cool to see those.
Yeah, it's cool.
Have you heard of, Tamara, have you heard of that third mobile window thing?
How am I gonna look that up?
Yeah, really interesting.
Like, I keep thinking of patients, I'm like, oh, this person.
Yeah. Okay, so here, first thing I did is, you guys are probably like, what? But this is the very top, this is the superior canal here on the left side. So the superior canals kind of are oriented like this. And so we're looking at the very top of it, but this is the space inside. Because CBCT is really good at capturing anything that's very high density change. So we see air versus skin versus bone, cortical bone, airway. So if there's water inside of the superior canal, so we can see the water, and then we see the temporal bone, which is surrounding it. So then I can find that, and then I just line these slices up. So now I can look at this slice, which is right over the top of it, which we can then see here. And then we can see those canals. And then I can just kind of go through the slices and slide it around to see, isn't that cool? So this is actually the cochlea.
Wow.
And then inferior canal, superior canal. And then we'll just slide up and see if she has any dehiscence. It's looking good, comes all the way around. She's got full coverage, so she does not have a canal dehiscence on this side. So what I'm doing is I'm looking at that hole, because then we're coming around to see, is that hole fluid? But if there's a gap where the hole is no longer solid, then we will know that there's no longer, call it coverage, there's no longer the bone. So the theory as to why this happens is that if there's too much pressure on one side or the other, so if there's too much pressure from the brain pushing down onto this portion of bone, that temporal bone, it thins down the bone and then now it's no longer hard, so it can flex and move. And that's where that pressure comes from, because now your ear can no longer pressurize equally, or a rainstorm comes in and the barometric pressure changes and you feel it. So that can be a lot of ear pressure. Yeah. But that's just the craziest thing, actually. You can really
That's pretty
see
cool.
it right there. I also look a lot at sinuses.
I was just gonna say,
What was that?
I was just gonna say, I'm wondering what the sinus is.
Yeah, she has a little bit of sinus stuff. And this is like an uninteresting CBCT. So we could look at way more interesting ones. This is just the one that I have CineX on. So I wanted to show how like her CBCT, relatively normal, but her CineX, we will see, is definitely not. So here is the sinuses. She does have a little bit of thickening of the mucosal wall, so this should be airway, which would be, you know, dark black, should be completely black, and then cortical bone along the edges. But you can see it's just kind of fuzzy in through there, and then it's very fuzzy down here, and then we see cortical bone. So she's got a little bit of filling into the sinuses. And the reason the picture quality looks not very good right here is because she's got tons of mercury fillings. I saw her today and I was like, you need to get those out like tomorrow. I would get all of those taken out ASAP. So you can see some of that. But I see some crazy stuff in the sinuses. Yeah, any other questions on this one before you go over to CineX?
Thank you for sharing.
Yeah. Okay, let's look at, we'll do flexion extension first. What's the best way to get this to work? This is not the best software to view it. It's so much better on NNT, but I don't have that on this computer yet, because I just got it working now, 5:15. So this is the dens right here, and then this would be that anterior tubercle of C1. So what we're looking at with flexion extension for craniocervical instability is an opening of this space right here. We already see it open. We can already see a little bit of a gap that has formed right there. And then it gets really big. So now it's like the full pinky width. So the dark line right there is that cortical bone of C2, and then the dark line right there is the posterior margin of the anterior tubercle. So she's got quite a bit of instability, and we see it here, but like I mentioned earlier, the true problem isn't here, it's here. Because this is her spinal cord, this is her brainstem in that space. So that means the atlas, when she moves her head forward, the atlas is now impinging on the space of her brainstem, which is not good. And there we can see that's where it gets the biggest, right at the very end range of the video, so we can see that space. I think the open mouth view is going to be easier to see. We can also do the assessment for the lower cervicals on this too. Let's see, there's full end range of motion with the lower cervical assessment. How do I get it to go away? Maybe I see plain. I don't know how to get that to go away. So lower cervical assessment, we're looking for any breaks in the back of the vertebral body, so they should all be lined up. And so we're looking to see if there's any translation of those vertebrae. She doesn't have any in the lower cervical spine. But open mouth view, These ones are a little tricky to take. So I don't know if it's the safest methodology, but what I do is the CBCT, you can change the orientation of where the anode, whatever the thing that emits the X-ray into the bucky or whatever it's called, the other part that like receives it. So I just turn it so that it's facing away from me, and then I'm watching the patient from behind and telling them what to do, but the radiation's going away from me, so I'm pretty sure I'm safe there.
You're plenty safe to do that.
Okay, good. So this one's really cool, but very hard to see to get the right spot. But
I must say too, that the images you're looking at are on regular TV, and then when you have the medical grade monitor, what you
yes.
see,
Very
even on my
different.
screen, you're smaller, right, it's just very fine what you can see.
Yeah.
Like literally HD.
So here, dense, thumb-like projection in the middle, that's always a good point of reference, so right in the center. This is the space in between C2 and C1, and then we're looking for any overhang. There should be 0 overhang, that should not be going over at all. It should be right, we call it juxtaposition, so it should be completely juxtaposition. She's got a pretty good overhang there on this side. And I can see it really clearly on my screen, so yeah, this TV is not the best. And there we can see it on this side too. Right there, really good view there. So that's like a 1/2 centimeter, probably 5 millimeters of overhang. That's a lot when we're working with CCJ real estate. Like, that is a huge amount because it's not here, right? It's inside, that's the problem. So this tells me that she has alar ligament instability. So that alar ligament that should be holding that in place is damaged. And you could do an MRI, a very precise MRI, to actually be able to see where that damage is at. That, there's a print off of this article, and this is Scott Rosa. He's a evo, you guys need to get in touch with him. So he actually does an upright MRI. And then he works a lot with, so here, no, that's oh yeah, right here on page 29, which is the second page, if we just open it right up. So this is where you would actually see the alar ligaments, and then, so we're looking for alar ligament. This is a print off, so this is not as good as the true PDF, but that's what we would be looking at for this patient to see, is there a damage to that alar ligament? And the only way to really see it is this MRI. An upright MRI, when it has to have very, very thin slices, because most MRIs, the thickness is too thick, and you would just, that ligament is so tiny, you would just skip right over it. So they have like proton densities, there's a special protocol in order to get these. So then that's how you would be able to see them. And then this also has some of the pictures of the CCJ anatomy, thinning and disruption of the membranes. So if you had an MRI, you'd actually be able to see what is torn. This tells us something is wrong, something is torn, but then the MRI gives you the actual data, which is helpful if you're gonna be doing like injections or something like that. And then this article also has some really cool stuff on cerebellar tonsillar ectopia, which is a passion of mine, but that's a different day. You cannot see that on this. Yeah. You guys wanna look at another one? You feel like you've seen what you wanna see?
So what would be the treatment then when you see that, like moving forward?
Yes, that is the question. Dr. Puvo and I were like just talking about that. What do we do next? So adjusting is very important, and that can really help a ton. For some of these people, they hold their adjustments very, very well, and they do great. And then some people, they just don't hold well. And it's really up to them of what they want to do. The most invasive procedure would be to do a fixation. So actually go in and do a surgical fusion of the area so it doesn't move anymore. That's kind of worst case scenario, right? And then there's other options. So adjusting would be the least invasive, but then you could also do injections. So that's kind of the space that I'm interested in referring for. Centennial Clinic and Hauser are the only two in the country that are doing these upper cervical CCJ injections. But if I had a patient who had, which I do, of like a lower cervical, C5, even C3, C5, like a lower cervical, you could do injections very safely.
Like
easily.
steroids?
Not steroids, they would be stem cells or
Okay.
PRP.
Okay.
So PRP is protein-rich plasma. PRF is becoming a little bit more popular now too, which is protein-rich fibrin, I think is that one. So that's where you do an injection that causes local inflammation to initiate the body's natural response to healing. So that's kind of the next step. There's a lady supposed to come tonight that was gonna be doing that. She does those injections. So I was really curious to hear what she does. You don't actually inject the actual ligament. You would kind of bathe the ligament in the stem cells, and that then the body will then heal that area.
Who does that?
In Spokane, there's a couple. So Dr. Pasma at the Regenerative Institute, Dr. Lanu Integrative Medicine, and then here in Post Falls, there's a CineX. That's a popular brand of regenerative injections, and those are all over the country. And there's one in Spokane, maybe even two in
Where
Spokane.
did they get the stem cells from?
Usually umbilical.
Okay.
So when you give birth at the hospital, they take your umbilical cord. That's why they sell it for probably $200,000. I tried to get my own, but they said no. Got the placenta, but it's not strong. And now I got dehydrated. Yeah, so that's kind of the idea is, sometimes people can respond well to PT, but you have to have the right physical therapist who's gonna be able to address this. It's not like you wanna start doing intense exercise, cause that's gonna make people worse. Yeah. What have you done for people like this, as far as treatment therapies?
So a lot of them respond really well to like vision guided rehab. So like in our office, we have a big like map where we'll put a headband on them and just do like joint position feedback. So we'll put a laser on the headband and they'll like track targets. They respond typically pretty well to vestibular therapies too. Or vision therapy.
Retrain the software so that they don't push themselves too far.
Yeah, and these parts of the neck are like so densely innervated with proprioceptive nerve endings that like feedback to the brainstem that pair with what your eyes and your inner ear say. And so it's all just one giant network. And you can usually work one system that works well to rehab the system that doesn't.
Yeah, makes sense. Yeah, the upper cervical spine, like the suboccipital triangle, it's kind of like, it makes sense that those muscles are for holding your head onto your neck, but really their most important job is proprioception. There's so much more proprioception that happens in the suboccipital triangle than there is function. The big muscles are what stabilize our head, but the suboccipital triangle is 90% proprioception. Yeah. If anyone wants to get a CineX, you want to see, or a CBCT and see what's going on in your spine, we could do a demo tonight because we have the machine. But also anyone, audio's all about it. And then if you want to come back in the future and do some imaging, any of the providers that want to come in, I'll do free imaging for you too. And so that's a helpful way to know how it works, what does it do, because you don't really understand it until you experience it. So to be able to come in and see that process and actually experience it, like, well, this is what's gonna happen, and then you can walk them through that. So I do typically an evaluation and exam, and then this imaging. But if you have a patient that you're like, man, I don't necessarily think that they are a candidate for upper cervical care, but I really wanna see what's going on the inside and I wanna do some imaging, then I do like an imaging center where I can do that imaging for you too. Like I mentioned, I can do just the DICOMs if you want the raw files and analyze it yourself, or those Loom videos. So, have those Loom videos been helpful?
Yeah.
Yeah. Good.
Definitely.
And they don't take that long for me to make, and obviously I love doing it, so it's fun. Yeah, any other questions? Okay, cool. Awesome, well, thank you guys for coming.